Thank you, Dr. Jumbo. I have a question. My name is Dr. Asaba. What are the components of lactose in the management of asymptomatic uterine fibroid? Right, thank you, Dr. Eze. Well, if you say component, it depends on the patients that you are with. If it's a perimenopausal woman, 48, 49, fibroid size, 14-week size, no menorrhagia, no issue. You know that the fibroid is dependent on what? On estrogen. And by the time she becomes menopausal, those estrogen effects are what? Are down. Such that you can watch that patient. She comes to you, the scan confirms uterine fibroid. There's no symptom. And you know that very soon she will become post-menopausal. That fibroid will begin to shrink. There's no need. So for that patient, you just individualize your patient. All it just means, for those that are coming, let's say 26-year-old girl or lady, not married, and then is coming with a fibroid size, 14-week size, no symptom, no menorrhagia. You need to, as much as possible, follow her up in terms of regular ultrasound. She will even be telling you how progressive the fibroid is what? Increasing. And by the time you see the fibroid that was 14-week size, now becomes 22-week size, will you still be leaving the lady? No. So you need to individualize that patient. But what are the components, as you are trying to say, is that individualize your patient, follow her up, not just leave her, and see that she remains what? Asymptomatic. By the time she becomes symptomatic, see what you can now do what? And offer her.
Okay. We'll soon go online to ask some of the questions from our participants online.
Thank you very much for this. My question is, I've had a couple of two cases whereby the fibroid size was really small according to the scan, but they said they could not operate on it because it was small, but it was symptomatic to the extent that the person even had anemia. The person developed anemia. It was around 20% or so. But she came to the hospital and she was told because of the size that they can't operate on her. But it's affecting her quality of life. So FMC Asaba. They told her in FMC Asaba, FMC only. They said the size is too small that can't be operated on. So I don't know, how do you improve her quality of life? You understand what I'm going to say?
All right.
All right, thank you for your presentation. Just practical experiences. Just like we were trying to say earlier, this patient is already symptomatic. She needs treatment. Do you understand? Somebody coming with PCV of 12% is worrisome. So, but when we are looking at it, do a thorough evaluation with ultrasound and see the options you can give her, because most of this hemorrhage as a result of submucous fibroid. I have a patient like that. It's just only polypectomy that we did, and that's all. And she's fine. Or if it is pedunculated intracavitary, you can send her for hysteroscopy. They will chop it out, and that's all for her. Doesn't need extensive surgery. So that's what we are looking at, appropriate evaluation of that patient. But if it's worrisome, she can go for myectomy. You understand? But by and large, looking at her age and looking at maybe she's not married, she's not thinking of future fertility, there are other options, medical management. We can manage it with what? We have methylamic acid is there, we have tranexamic acid is there, we have intrauterine system. It's an innovation. You just put it, it's an IUD, but it has progesterone. You have served her for family planning, but the essence is to stop this bleeding, because it's this menorrhagia that can cause mobility and mortality. That can suffice for her till she's now ready for what? For proper surgery. I don't know whether we have heard you.
All right. Can I just make, because this is a live, big live. I think that patient needs hysteroscopy. You need to decide that. So if the doctor should see cannot do that, they better refer to where that can go.
Right. Thank you, doctor. I think we need to fast track a little bit. All questions, please write your questions down. Sorry, sir. I spoke now. Doctor, don't go anywhere. I'm saying you are not good. So you see. I can tell you what to do for now. You can, but we will have to take on the second presentation at this point. Please also, if you are online, please note your questions. We will still get back to them, but we're trying to catch up for lost time. So it's important that we do so today. I would like to call on our next paper presenter in the person of Dr. Victor Ajayi. Victor Ajayi is a consultant gynecologist and obstetrician, also practices in the fertility space extensively. He's an assistant director of the Nordica Fertility Centre, and someone we also hold very dearly. So we'd like to put our hands together for Dr. Victor Ajayi.
Yes, thank you for that introduction. Good morning. It's almost afternoon now, but I say good morning, a minute to 12 to everyone. Happy to be in Asaba and happy to interact with you today. So, Dr. Jumbo has done a good job talking about open myectomy, but I must say that the trend now is to try to go towards minimally invasive treatment options and even non-invasive treatment options. So I'm going to talk more about the minimally invasive treatment options for managing uterine fibroids. Can I have the first slide? Okay. Okay, so I'm going to introduce the topic, just a little bit more discussion on that. Dr. Jumbo has said a lot about that. We'll talk about types of fibroids, what the symptoms are, when to treat, what the treatment options are, emphasis on minimally invasive methods, and then we'll conclude. I have nothing to declare. So fibroids are abnormal growth of the uterus. They are very rarely cancerous, so generally they can be said to be non-cancerous growths. They originate from the smooth muscle of the uterus, so that's why they are called myoma. They are the commonest benign tumors in women of productive age group. And they are one of the reasons, I'm sure most of us here, this is one of the main reasons clients or patients present to us. So they are one of the leading reasons why women present to their gynecologists for treatment. Incidents, different reports have put different figures, but there are figures as high as 70% by the time a woman gets to 45, 50 years. We do not know the cause of uterine fibroids, but some risk factors have been associated with the development of uterine fibroids. And just being a black woman makes you more at risk of uterine fibroids. We do not know whether it's genetic, whether it's food we eat, or other things. But black women have been said to be 3 times more likely to develop uterine fibroids than other races. So, one of the risk factors is advanced age, and typically in this environment, patients present late to the clinic, to the hospitals. So fibroids have been shown to increase as the woman ages. And we reported a study where we looked at sizes, numbers, distribution of the uterine fibroids. And the mean age of presentation of these women who presented with fibroids and had laparoscopic mammogram was about 38 years. You know, and we also see that even for women who for infertility, sometimes we see a lot of patients that had presentation for infertility with uterine fibroids, and also those women who present for infertility usually come out about that. We also have a study that shows that, and that is late presentation. Again, just like I've said, just the issue of infertility, women who are not conceived have been shown to be more likely to develop uterine fibroids. In general, I'm sure most of us have had this that, okay, the womb who are looking for pregnancy compensates itself with uterine fibroids. That's a lay person way of looking at it, but really, we see an increased number of uterine fibroids in women who have not conceived. In fact, this study showed that women with primary infertility were more likely to develop larger fibroids and more fibroids in terms of numbers compared to women with secondary infertility. So not conceiving is a factor. Fibroids are named according to their location. So, usually when we interact with patients who are late, this is the way to describe fibroids. The submucosal, the one in the cavity, and that is subserosal in the wall, but that's a tramural in the wall. Subserosal is bulging out of the covering of the uterus. And then peduncle subserous or peduncle submucous. But people have done further classification, which you can use this to interact with colleagues and also to plan patient management and also prognosticate. Okay, so Dr. Jumbo has also mentioned this classification by
symptoms also symptoms of fibroids, heavy menstrual flow. Sometimes that's the reason why they are presenting patient just spoke about. And commonest reason for type of fibroid
is the submucosal type. So just like Dr. Jerry had just said, that patient should have a hysteroscopy and see whether there's a submucous fibroid and deal with the painful periods. Sometimes that's just the presentation. Abdominal pain, pelvic pressure, can be a problem. And sometimes this can lead to recently had a patient who had a big fibroid, got pregnant by IVF, and I think that combination resulted in her having DVT. So it's something that we should take into consideration. When you see leg swelling, abdominal mass, this could be one of the problems. Urinary symptoms, pressure on the bladder, that can be you see with increased frequency and all that. Enlarged abdomen, sometimes it's taken as a pregnancy, shown in the picture on the screen. Rarely, infertility, we do not believe that fibroids can be said to be causes of infertility. But of course, depending on their location, depending on the size, they may block the fallopian tube. The submucous type may disturb implantation of embryos, and it will also cause miscarriages, recurrent miscarriages. so they will come to you with infertility. So which women should we treat? Not all fibroids need treatment. I think we need to know that. What are the points to consider? Size of fibroid, okay. So, for instance, if you have a 45 centimeter fibroid, intramural fibroid, you may consider treatment, especially those of us in infertility practice, because it is said that the uterus itself, what is the size? Okay, and then you have an intramural fibroid, 4 cm, 5 cm, because that kind of fibroid is likely to have affected the junctional zone, and that can affect the functionality of the endometrium and implantation and all that. So you may consider treatment when fibroids are 45 cm, intramural fibroids. Also, mucous fibroids, the advice is to treat. One, because of symptoms. Two, because if you're going to try to conceive, this is a type of fibroid that can also disturb conception and can also lead to current miscarriage. In terms of location also, when you have fibroids obscuring the view or the reach to the ovum, again, I'm speaking from fertility specialist point of view, so to speak, because for IVF, you need to retrieve eggs. And if you have a fibroid that is in the way, that can be a challenge. So you may want to take care of such fibroids before going ahead. Fibroids that scans have shown that distorting the endometrium is also very important to take care of such fibroids because it may compromise pregnancy or chances of pregnancy. Current symptoms, menorrhagia and PO, or anticipated symptoms. Sometimes you look at this fibroid and say that, yes, you are fine now, but when you get pregnant, it's likely to cause a problem. It's likely to. Sometimes they get bigger, they remain the same, issues of brain degeneration and all that, and risk of miscarriages and pain in pregnancy, you may want to deal with it, or difficulties in delivery. So the operative deliveries and all that. So this no treatment, we should also look at this. This message is for both patients and doctors, because sometimes we have a 2 cm fibroid, we have a 1.5 cm fibroid, and we say we want to do a myomectomy. No symptoms, none of these things that I said earlier applies, and we want to treat. Patients also need to be properly counseled. We see patients in our center who is scan and they are just relaying the findings. There's a small intramural fibroid. She won't sleep. She says you have to take out that fibroid. So no matter what you say, she wants. But we as experts who know the risks for treatment when there's no need to counsel them. Again, this has been discussed extensively. Open myomectomy, so I'll just keep that slide. But the thing with open myomectomy is that there are some risks associated with it. Apart from open myomectomy, we have people who do traditional treatment. And I'm sure in our practice, we'll see such women who say, I inserted something in the vagina, so told me to put some caustic substance in the vagina. And it led to gynecology. We've seen such patients. So, open myomectomy, some of the risks include super damage, scarred uterus, which may affect implantation when you transfer embryos into IVF, and IVF failures, miscarriages, bleeding in pregnancy. And sometimes we see cases where the endometrium has been so damaged and with admissions, and we have to talk about surrogacy, which is not very acceptable in our environment. We reported a study. We looked at over 1,000 patients who had hysteroscopy, and we found that up to 60% of them had one problem or the other in the uterine cavity, and half of them had intrauterine admission. And when you ask why, what they did before, majority of them did open myomectomy. Yes, you cannot 100% say that's why they have these admissions, but that's likely a risk factor. Because B&C was the next one, followed by cesarean section. But this study that we published and looked at the risk factors for intrauterine admission actually showed that the women who had intrauterine admission were 2.5 times more likely to have had open myomectomy versus those who did not have intrauterine admission. So it's a risk factor that can follow open myomectomy. So laparoscopic myomectomy is essentially a keyhole surgery. Okay, when I try to explain it to patients, I say it's like you stay outside the door of the room and you're looking through the keyhole. Okay, you've not gone into the room, but you can see a large part of the room, essentially the whole of the room. So that's what laparoscopic microscopy is all about. You are looking through a keyhole to see the abdominal cavity, and then you can operate. Some people also describe it as using longer hands to operate. So the laparoscope is shown there. Okay, that's the laparoscope, and then you make other ports, other incisions. 3 or so, 3, 4 incisions, and then you try to take out the fibers. There you insert your instruments to there and then take out the fibers. So incisions are really small, 1 to 1.5 centimeter incisions, and then you operate and take out the fibers. So the fibers, how do we take out? So taking out the fibers is done by a process called morphization. Because some will wonder, okay, you remove the big fibroid, 4, 5, 6, 7 centimeters. How do you take it out through these small incisions? So you have to make a separate pot, okay, which is slightly larger, and then you will shred the fibroids. Okay, I showed you that picture. Shred the fibroids this way, and then they are pulled out from the pelvic cavity and then collected, and you can still have samples for histology. So in our own practice, we do want to shrink the fibroids before we go on. So we use generic egoids for 3 months. It's a monthly dose. We try to use a monthly dose for 3 months. We have to shrink the fibroids, and we think that helps the process. Doesn't affecting the plates and all that has not been a major concern for us in our own experience. So we use 3 doses of generic egoids, the monthly dose, to shrink the fibroids before we proceed. I must say that in cases where it's fertility, there was IVF, we may want to sometimes collect the eggs first before we use these medications and proceed to management. How do we close the wound? We initially were using staples, okay, but now we use gamma bonds, which is like a glue that stick the edges of the wound together, and of course the outcomes are good. You can see this picture. One of the advantages of laparoscopic myomectomy is the cosmetic part of it. You can see that first picture there. That's laparoscopic myomectomy, and you can hardly see any scars there. Open myomectomy, you can have this type of scar, scar, and then you can have the midline scar also. There. Okay. So we also did a report. We've done over 100 cases of laparoscopic myomectomy so far, and we looked at some of them. That report was actually only about 31 cases, and we saw that there are several benefits. One of it is, firstly, is minimally invasive. There's less scarring. Okay, the cosmetic benefits. The shorter hospital stay, our patients stay 48 hours and they are back home. So that shorter hospital stay is a plus. Quick return to normal activity. In 5 days, also less than a week, they are back to their normal activity. Less blood loss or need for blood transfusion, and generally fewer complications from laparoscopic myomectomy. Yes, as in every procedure, there are possible drawbacks. Longer duration, sometimes they take longer to do compared to open myomectomy. But as we shall see later, patient selection is very key in this cases. Sometimes we need to convert, not so common, but estimated that about 1 in 20 cases may need to be converted to open surgery. Maybe technically demanding, so the skill has to be there to do laparoscopic myomectomy. Stereoscopic myomectomy, in this case, we're talking of some mucous fibroids. These are fibroids that are basically inside the cavity of the uterus. And that classification is shown 0, 1, 2, depending on how much of the fibroid is in the uterine. 0 when the whole fibroid is in the uterine cavity, 1 when more than 50% in the cavity, and 2 when less than 50% in the uterine cavity. We've done, as at the last count in December 2021, we've done 4,319 hysteroscopies. So that picture that is talking about is like the type 0 hysteroscopy which I just mentioned. We found that in this report, this one, the one we looked at it, over 1,000 cases, we found an incidence of 15.5% of submucous fibroids in this category of patients who presented to us. So, for submucous fibroids, hysteroscopic myomectomy, in this case, there are no cuts at all. Okay, same day, the patients go home the same day. The additions that we spoke about, Dr. Jungo spoke about, additions are less likely to occur when you do submucous, when you do hysteroscopic myomectomy. So that's it. Just go through the vagina with the hysteroscopy, do your diagnostic first, look at your submucous fibroid, and then we can now resect with a resectoscope. And essentially just slice out the fibroid. That's the loop there, and then slice out the fibroid. And it's the same day procedure, the patient goes on the same day. Okay, so I'll just mention one or two words on uterine fibroid implementation. Non-surgical method also. Basically, this treatment option is just cut off supply to the fibroid. So small particles, gelatin particles are injected, using a catheter to kind of block the tiny fibroids that supply blood to the block the vessels that supply blood to the fibroid, and then you can they stop growing. So, that can relieve symptoms. But we don't, especially for those of us in infertility, not so keen on this because they are concerned about future pregnancy in cases of uterine fibroid embolization. And injury, some of the risks also include injury from artery or uterus, failure to treat the fibroid, you don't target the vessel that you were supposed to target, possible problems in future pregnancy, lack of periods, menses, that can be a problem also. Problems with ovarian function, because vascular supply may be impaired to mature menopause. Again, no samples for histology. The other two I mentioned, the lab myomectomy and hysteroscopic myomectomy, you have samples for histology. And so one of the drawbacks here is that you may miss the rare cancer from fibroid. This is completely non-invasive, okay? High intensity focus ultrasound, which Dr. Abang is going to talk about. So the trend, as we've seen, is to move away from the invasive myomectomy towards minimally invasive and even nowadays non-invasive treatment methods. What are the important considerations? I've also said is patient selection is very key. So for laparoscopic myomectomy, usually we look at fibroids that are not more than 24 weeks. When you look at the size abdominally, you look at the number of fibroids also. This is relative. So there's no fixed size, but people with multiple fibroids need to have an idea of what the size, what the number of the fibroids are like, what the sizes are, and then before you select the patient to go for laparoscopic myomectomy. Previous myomectomies, we mentioned the issue of this scar and how to because even for myomectomy, when you have to repeat myomectomy, you have to be careful. Midline scars, usually you don't want to go for lap myo if you have midline scars. The panestio is better. And in our tradition, as much as we want to see a report of that previous myomectomy, but sometimes that will guide us in taking a decision. Because we have cases where the report says the pelvis was frozen, and so this of addition. Sometimes we have to do MRIs to see what the overall configuration is like. And then look at in summary, we weigh the risks properly before going for laparoscopic myomectomy for women who have had previous myomectomy. Experience is very key. So it's very important to ensure that the person doing the laparoscopic surgery, even the hysteroscopy, has the experience. So, fibroids are common among women. That is a given. Their presence may sometimes cause problems. Not all the time, but they may cause problems. And then when there are problems, treatment will be needed. The trend now is towards less invasive treatment methods. and minimally invasive when possible, or non-invasive methods are recommended for best outcomes. Some references. Thank you for listening.
Doctor, so also don't go anywhere. We're going to have this close by so that when we go into the question and answer session. I think maybe Doctor, what we should do is to take the third presentation, then we'll then do all the questions together and see how fast we can move. Thank you very much, everyone. So I'd like to come. Okay, well, maybe we'll take one or two questions live here while we quickly turn on the next presentation. So if you have any immediate questions. Okay, thank you. Please kindly introduce yourself, sir.
Good afternoon, everyone. I'm Dr. Koye Oka from FMC Asaba. I want to ask about I want to ask the presenter about his experience about parallel laparoscopic and hysteroscopic mammectomy.
And you help us with that.
Yes, when that is indicated, we do so. We have patients sometimes with intramural fibroids, also have some mucous fibroids, especially when you have symptoms, when the woman has menorrhagia. In fact, we've had cases where the first thing we go for is hysteroscopy because we need to deal with the symptoms. Yeah, so we've had a combination of laparoscopic mammectomy and hysteroscopy. But generally, what we also do is that after a laparoscopic mammectomy, 3 months later, for those who are seeking conception, 3 months later, the standard is to do a hysteroscopy. In case you missed any of mucous fibroids, in case there's scarring, okay, so you need to deal with that before you proceed.
Thank you. I'm Dr. Oseji, consultant public health and community physician. Please, you mentioned that you have done 4,319 hysteroscopies. Is it different from hysteroscopic mammectomy? I needed to, because I just wanted to be sure of that. And then secondly, what is the difference in the cost for the open mammectomy and then the keyhole mammectomy? Is it like keyhole is half the price or double the price of the open mammectomy? Okay.
Yeah, so the 4,319 cases I mentioned are hysteroscopies generally. So hysteroscopy can be done for other reasons. Just checking, diagnostic to see whether there's any problem, previous mammectomy, check for scarring and all that. So not all of them are for mammectomy. I want to do open mammectomy these days, so I'm not able to comment on how much it is. But I think, generally speaking, in a good hospital, speaking about maybe what of them in Lagos, it's about the same thing. If you look at the cost of laparoscopic mammectomy and open mammectomy in top hospitals, and but when you now weigh that cost, even if it's less, the open, if you weigh the benefits versus cost, I would rather say you go for the laparoscopic mammectomy. Because these complications will mention how much are you going to spend to take care of them. Sometimes you can't people get pregnant again, and that is something you can't put in terms of management.
Right. Thank you very much, Doctor. I think we should swing into the final presentation for today and go to the question and answer sessions. Then we'll take a round. I'd like to invite Dr. Abba, who is speaking about high intensity focus on this type.
Well, thank you so much once again. I think this afternoon I'm so lucky. Two brilliant speakers have spoken before me, so they render some of my slides non-consequential. So I probably just jump to the main event. But maybe one or two things that I'll talk about before I go to my slides. It's that there are options for women with fibroids. That's what they take home. I'm not saying that every of your patients should do high. I'm not saying that every of your patients should do minimally invasive surgery. I'm not saying that all your patients should do open magneto. What we're saying is that there are options, and we can look at the options and the four things that we try to consider when we're determining the best way to treat the patient is the age of the patient, like Dr. Jumbo said. We're looking at the symptoms that she presents with. We're looking at the location of the fibroid. And that's why the fecal calcification is important. And the fourth thing we're looking at, does she still want to have children? Those four things are the things that you must consider to be able to advise a patient on how to go about the treatment. Well, most of these things have already been said, so I'm just going to go straight to HIFU. I'm going to see almost everything they told you about the clinical presentation. Maybe one other thing I want to talk about is that, which probably has not been, Dr. Jumbo made some reference to it, about the renal affectation. Some women have very big fibroids, and really and truly, it's the backflow of urine into their kidneys, and over time they have renal failure. And one other thing Dr. Ajayi mentioned is DVT. You know, we're not picking up these DVTs, and these women how can somebody carry this huge mass for about 10 years? And they come to us, sometimes they talk about leg pains, we just leave it away. And some of them die because they have pulmonary embolism from the DVT. So that's one of the things I want doctors in Nigeria to start paying attention to. Some of our patients with this huge fibroids that they've carried for very long actually can have DVT. And unless we look, we will not see. Maybe that's there was another thing I wanted to talk about, but maybe I'll remember over time. So they talked about it. Dr. Jumbo also talked about the usefulness of imaging in diagnosing adenomyosis, because it is not everything that we call fibroid that is fibroid. And that's one of the things that actually leads to this repeat mammectomy that people, you see somebody saying, I'm going for a fourth mammectomy. Come on, are you the only one? Now that you are careful. You understand what I'm. Sometimes it is not fibroids. And you know the way our patients behave. They walk from one doctor to the other without any medical report. They believe the doctor does not know what. That's not it. But the diagnosis is wrong. So we should look at many more patients doing imaging, and probably, and you know the thing about scanning, like there also is that there are very few certified scanners. So very few people can differentiate even adenomyosis on scan. It's really possible, but it's the ahead of scanning. And unless very few people can do that. So MRI might still be one of, and I sometimes even after the MRI, you get some very funny reports, because I think we are buying more machines than training people now in Nigeria, even when it comes to MRI. So, but it's something we just have to live with it. We all have to pay attention to training, because, you know, when I look around now, I'm able to be prepared. Who are the people attending this kind of thing? I don't know the people online because I can't see them. But it's the older people that are coming for training. The younger people are still hustling. But I ask myself, what are you hustling if you don't have the skill? Do you understand what I mean? If you do not know what differentiates a doctor, it's not the number of hours you sit in the consulting room, it's the stuff that you are able to do. What do you know? What is your unique selling point? And training is the only thing that gives you that unique selling point. So we need to still see how we continue to train ourselves. And then Dr. Jumbo has said this also, the treatment has evolved over time. Dr. Victor Ajayi has spoken to you about the minimally invasive. So I am talking more about the non-invasive, which is the high intensity focus of the study. Now, they talked about the complications of the surgery and the aesthetic complications. I think that's one thing also that is also very important in this crime, there's a lot of understanding problems. We don't have enough understanding. So there's no killing. Is it even going to get worse now that UK has opened its doors? Most of your doctors are going, and I'm sure it's happening in Asaba too. There's some hospitals in Lagos, you wake up one day, 10 doctors are one day, a private hospital. So it's really going to back us more. I hope we can do something about it. They've talked about hemorrhage, blood transfusion, hysterectomy, and intrauterine additions. The two of them spoke about it as well. And you see that sometimes, I don't know how to put this nicely because it has happened to me before, that your patients don't get pregnant after mammectomy, not because of the fibroids, but because of the work that. And that's why I was not going to hold my peace about the patient that you described. Because if anybody goes through the abdomen for that kind of fibroids, they're going to cause that patient more problems. I heard some doctors tell me that, oh, I'm very experienced. I don't care your experience. When you cut somebody and you throw back, there will be scar. Okay? And scar comes with additions. And so, if you do not need to cut, please do not cut. That's why Dr. Jay also said that it's not all fibroids that need treatment. Because each time you cut anybody, there will be scarring. So, these intrauterine additions, I don't think we should joke with them because some of the patients, even IVF, they can't get pregnant unless they do surrogacy. And some of us don't look at the mammectomies that we have done to see, to do hysteroscopy after them. That's why he said after 3 months, after laparoscopic mammectomy, we must do hysteroscopy to see have we done more damage or is what is, and if there is any scarring, can we break it down quickly, you know. But we know that laparoscopic mammectomy tends to give less additions. So what is hyphen? Oh, then why are we even interested? Because some people have been asking me that question. Oh, it's for Igbo people. No, that's not true. I asked myself the question. Why do we say patients report late in Nigeria? Why do they report late? Majority of them are afraid of surgery. They know I have fibroids, the only thing you can offer me is surgery. So I rather people stay with my fibroid until it becomes so big that, but can we have a method that does not involve surgery, that once you are diagnosed, it can be open to you? I am afraid of surgery. I'm sure of you here, if the table was turned and you are now the patient, unless there is no other option, nobody smiles to the surgical table. So I don't blame patients sometimes because now we're seeing 33, 32-year-olds and they have 36 liter fibroids. And you start asking them, yes, it's been there for 10 years. It's true, it's been there for 10 years, but because they're afraid of surgery. So I think that's what we think that IFU will be able to offer us to an option. Like I said, I'm not saying that every patient should do IFU, but this should be an option. What is IFU anyway? So this is a system, a non-invasive system that works with the ultrasound. It's not even X-ray. What it does is that it converts ultrasound rays to heat energy, and therefore there is tissue necrosis. It causes tissue necrosis, so it kills the fibroid. I will show you if I can in hand. The principle is based on, you know, as kids, we played with a magnifying glass, and we say we were doing magic. You use a magnifying glass to put a piece of paper on the table, and you get to a distance where the paper catches fire. Because what we have done is that there's a focal point on the paper, and then that's where the heat energy there makes the paper to catch fire. If you put your hand in between the paper and the magnifying glass, it doesn't burn you. And that is the same principle that HIFU uses. It converts ultrasound rays to a point, and then it converts it to heat, and then it burns that same place. Of course, there will be scattering of energy sometimes, but that is where it has a maximal effect. So we can see now this is like the focal point, and that's why it fits. Sorry. Oh, okay. Oh, I'm sorry. Thank you for. Is it better? So I will lose. I won't be able to see it. But it's okay. You will see the most important thing. So, who are the people who qualify for IVF? Patients with uterine fibroids or adenomyosis. Now, this adenomyosis is a tricky one. I saw a paper from University of Jos where they looked at the specimen that were removed from hysterectomy samples. And they saw that about 30% of these patients were not diagnosed before the hysterectomy was done, had adenomyosis. So it shows us that adenomyosis is with us, but we're not making diagnosis of it. And that's one of the things we have also seen in our experience with hyphen now. Now, so patients, like we said, must have symptoms, either like they said, menstrual flow is increased, dysmenorrhea, or like big fibroid uterus. And the patient probably does not want surgery, cannot tolerate surgery, or does not simply not want surgery. Now, there are some fibroids that we cannot touch with hyphen. From what the two speakers have said, the zero, that's the intercavitary pedunculated. Why? Because if we do this, it's going to drop into the endometrium and the degeneration, the infection, and so on and so forth. So we don't want to do that. Hysteroscope is best for that. And then we don't want to do type 7 as well, which is this, because this week is going to drop into the abdominal cavity. So laparoscope is best for that. So we don't want to talk to those people. Oh, okay. Okay. Okay, so our patients who have done liposuction and therefore the abdominal cavity, the abdominal wall has been displaced. Patients who are not suitable for analgesia and sedation, maybe they react, or patients who cannot lie down still for about 2 hours because the procedure takes about 2 hours. What is intriguing to me is the simplicity of the procedure. It's just that you need to sleep at the same spot for about 2 hours and you get up after that, and that's it. So, so patients who can also communicate we don't take them because you need to be able to tell us how you feel. For example, I'm going to take you through where we talk about some of the things that can go wrong, and then we know the importance of that. Absolute contraindications are patients who have done radiotherapy. Cancer is absolute no. Even if we suspect that this patient might have cancer, for example, you see that there are some changes in the fibroid that you cannot explain from MRI. We don't take them. We tell them to go and do open mammography so that we can have, because just like Dr. Jerry said, uterine artery embolization, we look after from this. So what we try to do is to make sure that we pick the patients and pick the right ones so that we don't run into the trouble of cancer. And this is the machine. The consists of 3 parts, which is this, which is that's where the software is, and like the operator is just like a pilot. He looks at, and this is where the patient lies on, and then this is the water the cooler of the system, because water is continuously passed through. The patient doesn't see it, she just lies on, but below where she lies is like a water pool. Yeah, there's like a water pool here. Yeah, what are the advantages? It's a day procedure. You come in, do the procedure, then 2 hours after, we watch you for about 2 hours after the procedure, and you're good to go. During those 2 hours, what we're doing is pulling the uterus that we fitted up, and then you're ready to go. It's non-invasive, so uterine sparing, you don't make any incision on the uterus at all. So the debate whether you're going to deliver vaginally or cesarean section after that does not come in. And because it's so precise, it's to the target. It does not affect your normal, like I said, whether the plan in future, whether you're going to have a CS or you're going to have a general. There's no general anesthesia. Faster recovery, you can return to work in days. Actually, if you finish 2 hours after, you go home. We will have given you what not to eat for about 2-3 days before the procedure. So the next day, you are eating, but there's some things we don't want you to touch. By 48 hours, you will have forgotten that you've done the procedure. Actually, I don't recommend it, but I discovered something that attracted me. One of our patients took this through military, and she did this procedure. And 72 hours after, she was on a plane to America. So, and the husband happens to be my friend, and so he was asking me about something. I said, "Oh, talk to the doctor." And he said, "Oh, but I'm asking you because my wife is already on her way to America." So it can be as brazen, as simple as that. So faster recovery, no ionizing radiation. That means you can repeat the procedure. There is no damage to the ovaries, because that's one of the things that, like Dr. Ajayi said, that some people are hesitant about some like uterine embolization that affect the ovarian reserve. This, no. Cost effective, you don't stay in hospital, there is no blood transfusion, so no risk of HIV, and very low complication risk. Now, I'm going to bust Dr. Ajayi's bubble, because this is the script after the laparoscopy. This is laparoscopy. This is iPhone. You can pick and choose. And this is what the uterus looks like. See, you know, laparoscopic surgery, this is a lot. Outside, it seems as if nothing happened, but inside, a lot of things have happened. So the uterus looks something like this, and this is what the uterus looks like after hypo. Well, that's exaggerated because it depends on how big the fibroid was before, even for hypo. Now, what are the complications of hypo? You will have pain. This is usually transient, mild, short-lived. You will have some ischemia at not the treatment site. The patient will have some pain at the treatment site, but it's very short-lived. Analgesic will take it away. She will have some pain at the buttocks, not much. And those are all those things analgesics will take away. But what we are very particular about, and that's why patients don't sleep, is that you must tell us if you start having pain in your legs. Because that can be something that is warning us that you can have nerve damage. And that immediately makes us to change. First, what we're doing, change the direction we're giving the energy from, and then we can start again. And then, of course, skin toxicity, because a lot of it is generated. The water where you're lying in might become a little bit too hot. So you need to tell us if your skin, you know that your skin, you're feeling too hot, you need to let us know. And that's why we don't send anybody to sleep. And so some people, especially, you know, the Caucasians can have blisters and burns. We've never had any. And then also bowel injury can occur. But this, once you can do, the patient sticks to what we have said, don't eat this, don't do this before this procedure, because ultrasound is not transmitted by gas. It's a poor transmitter of ultrasound. So we want to empty your bowel of both gas and feces before you do the procedure. So on the day of the procedure, we do an enema. And then once that is done, you are not likely to have any problem. And of course, the person doing the experience of the person doing the procedure, of course, comes in. And also there can be bladder injury before this is not taken into cognizance. And the endometrial damage is also a possibility. So, and that's why we don't take the fibroids that are the zero, because we must always give about 15 mm distance from the endometrium when we are shooting, so that we don't shoot directly at the endometrium and we have a endometrial damage. And like you said, now we do. So back to what Dr. Ajayi said, any procedure, the key is still patient selection. Any of the things that you can do for fibroids. Well, this was a study done in China, which involved about 20 centers, about 241, 2,400 patients, and to show that the adverse effect from IV was very minimal compared to surgery. Well, I don't think that is rocket science. But some people say, oh no, it's for Caucasians. No, but Chinese are not Caucasians to start with, and Chinese have huge fibroids too. Not as if they're their own, but they also have very huge fibroids. But this study was done in South Africa. Oh, by the way, there are only 3 of these machines in Africa. One is in Egypt, one is in South Africa, and then we have a third one. So this has been shown in South Africa that is effective and safe for use of in fibroids. And this also was the study from South Africa. And this is what I want to point out here, the shrinkage rate. Now I need to tell you something. One of the problems that we have with iPhone that we're being compared with surgery is not surgery. The result is not the same as surgery. This is what I mean. We don't take out the fibroid. We kill the fibroid. It takes some time for your body to now reabsorb that fibroid. So what we look at for is shrinkage rate. But the symptoms stop immediately. So if you have menorrhagia, because the fibroid, so what we try to do is to pick probably, some of our women are so they have about 15 fibroids or 20. And you have to probably look at for the ones that are most troublesome, because we probably can't do 15 at the go. And because it's also not like ionizing radiation, you can do 2 procedures for them. But what you try to do is look at the ones that are, for example, if menorrhagia is a problem, look at the ones that are likely to be causing menorrhagia and make sure they're the first ones that kill. So, but they now come back, either they go and do scan somewhere and the doctor will say, you still have fibroids. And the patient comes back to you and says, oh, doctor, you didn't do anything. Okay, your menorrhagia, oh, that's better. The urinary frequency, oh, no, that's wrong. So it's the expectation of the patient is one of the things that we still need to get to address. And of course, of the doctors also. Because the doctors now will do the scan and say, no, we didn't do anything for me. And of course, again in Nigeria, we have the peculiarity. So when we look at the shrinkage rate, for example, in South Africa, what they saw was that in 3 months it was 32.5, it was 42.3 in 6 months, it was 32.5 in 1 month, 42.3 in 3 months, and 52.5 at 6 months. Post height. Now we actually, yesterday we did that number 81. So this was last weekend. 76 patients were reported by last weekend. And 61 of them had uterine fibroids. That's it. All those ones, uterine fibroid is just great with the height. The symptoms just disappear. 9 of the patients had uterine fibroids and adenomyosis combined. 6 of the patients had adenomyosis alone. So you can imagine these 6 patients are gone for myomectomy. It's a bloody waste of time. There's no way. Except the doctor wants to do all this kind of, they call it all kinds of things. But then, if you still want to have children, seriously, I'll be careful to do such surgeries on women who want to still have children. So this is their experience from our own center, the Fibroid Care Center. Yes, we have looked at 39 patients 3 months after, 35.8, and then 6 months after, 2.8. And if you look at it compared to the South Africans, it's now what the South Africans did, which we not do, was they were measuring fibroid by fibroid. We looked at the whole uterus. So if we are looking at this fibroid by fibroid, probably our result might even be better. But if you see 6 months, the ones that we've done 6 months since, results are almost the same. This is from Taiwan, the result from Taiwan. Now there are about 29 countries now that have this machine all over the world. They've done over about 190,000 patients. The shrinkage rate, there are 2 ways that we can monitor that. We can use the ultrasound and then we can use the MRI. This is on ultrasound and this is MRI. So what has been our experience? It is that sort of were like drawbacks since we started. 11 patients complained of lower abdominal cramp. Don't forget, this is expected. 3 women complained of transient leg pain, went away immediately after. 5 women complained of lower back pain. We had to readjust their treatment, but they finished the treatment. 7 women complained of skin burning sensation, no skin burns. They just felt there. Now, the ones that really have complained after the procedure, because this was the immediate complaint, the one that complained after, 3 women complained of increased menstrual bleeding. 1 woman complained of pelvic pain. 7 women complained of mild watering vaginal discharge, which have subsided over time. The 4 women, the 3 who complained of increased menstrual bleeding, and the 1 with pelvic pain, are adenomyosis patients. And what adenomyosis means is because we could not burn everything, the bleeding of was widespread. And so what we're doing now is, because this is not unusual. So when we say adenomyosis, what we do is that we say, okay, after the hypo, you're going to be on DNA analog for about 3 months. But we know that some of them will still have pain after that. And therefore, we do Mirena insertion for them. We've not inserted Mirena for anybody as I speak now, but it's a possibility that we might consider. Because some of them also have infertility at the back of their mind. So telling them to come and have Mirena and then infertility, it's a contradiction for some of them. So I think, yeah, this is a happy woman who does have the hypo, and we are expecting many more people to join her. And that's why we're having this, because we also want to train doctors in the use of hypo. So that even if we, for example, in Asaba, we don't have a machine. Yeah, but if you get trained and you have enough patients, you can bring your patient if you want and bring the treatment yourself under the supervision of a doctor who have trained. It's only people that have been trained, but of course, for places where we don't have machines, we have to select very highly selected doctors. Thank you so much.
Thank you very much, Doctor. I think you also, you are not going anywhere so soon. So I think it's question and answer time. And, Well, you help me with this. You help me do all right. Let's see what questions we have. But let's take the questions all right away. Any questions in the hall? Okay, thank you very much, sir. You introduce yourself and then we go from there.
I would have thought that it would be also helpful to us to ask the high school, if you have an idea of how much it does cost the machine. For the sound. The machine per se,
Thank you, sir. The cost of the machine, I think we need to talk to the manufacturers to get the cost. I don't, because I cannot stick out my neck and say this is how much it's going to cost you. Because I got mine under some conditions. So I don't know whether those conditions will still apply or not. So probably if you are ready, sir, we can ask the manufacturers how much they are going to do. I'm not going to say that now, sir.
The other thing is that the price of the dollar last year is not the price of the dollar this year. So there are other things that could have affected.
It's dollar dominated, that's all I'm going to say.
It's dollar. All right, sir. Let me take this question.
thank you, sir.
Sorry, I'm told that there is cost of treatment too.
Yes.
Yeah, I'll still say the same thing and say that just like Dr. Ajayi said, what we are trying to do, like we are in Lagos. And we're introducing something that is completely new. So what we try to do is to make sure that the price is the price of what we get for open mammometry in a good hospital in Lagos. In fact, there's some hospitals that they will charge you more for open mammometry than what we're charging now for HIFU. So what we're charging now is 1.5 million for HIFU. So I know it's not cheap in any way. But I can tell you that somebody said something when we were talking about comparing open mammometry and minimally invasive. That when things really go wrong, nobody wants anything to go wrong. But sometimes at that point in time, you can't put monetary value to that thing. So, and that's what I'm saying, that it's just an option. We are not saying everybody should do it.
All right, thank you, sir. Dr. Essia, I have a few questions for you, sir. So I want you to throw more light on why liposuction is contraindicated in HIFU. Is multiple uterine fibroids suitable for HIFU? How soon can a woman get pregnant after HIFU?
Can you allow me to, I'm not getting any younger too. I'll forget some of your questions.
All right, sir.
So the first one, that liposuction. Yeah, because after liposuction, the anatomy of the abdominal wall is distorted. Okay. What we are dealing with is that we must be able to know where what is. If you're going to prevent complications like bowel complications and so on and so forth. Because the advantage that we have with this is that we are seeing the organs real life with ultrasound. And therefore, we want to be sure that we know what is, rather than we think it is there and that's not what we're seeing. So we don't want somebody who has not liposuction cannot do HIFU. Now, the second one, multiple fibroids, there a go. We take a go at them every day. Is there any, okay, maybe we have seen only one or two people that have solitary fibroids. Majority of them are 10, 15. So yeah, it's a go. We do that, we do. What's the third one?
How soon can a woman get pregnant?
Next question, 3 months. What we do is that after 3 months, we do is stereoscopy for them. Because majority of our patients want to do IVF. So we do a stereoscopy. Once they're good, then we can start IVF treatment. But 3 months after IVF, we can get pregnant. And that's the difference also between HIFU and the other methods of treating fibroids. I hope we meet any of questions. One more.
Yes, sir.
You are going to pay.
So I'm just being curious.
No, I know. I'm kidding.
In this era where you have interventional diagnostics, who is the right?
Fantastic question. With ultrasound, you see, when we talk about HIFU, there are two ways of monitoring what you're doing. You can do ultrasound, you can do MRI. With the MRI, which is not good for fibroids, because it takes you a longer time to treat fibroids. And that's one of the problems that fibroids have with HIFU, because in some countries they were using MRI. But now they're talking about MRI for prostate. Because you know, HIFU is a technology. It's like you have electricity, you can use it to boil water, you can use it for your iron, you can use it for anything. It can be used for almost anything. Actually, the first thinking was to use it for Parkinson's disease. You know, so it can be used on any. Some people even use it for cosmetology, for the skin. You know, so but for fibroids, your best bet is ultrasound, and that is best done by gynecologists. The guy in Egypt is an interventional radiologist. He does more of cancer than, because the same machine can be used for cancer. I am a little bit, yes, I want to have more evidence of cancer before we start thinking about. There's some selected cancers, solid tumors, that this machine can be used for. For example, liver tumors, pancreatic tumors, it can be used for it. But we are gynecologists for some problem. So let us do what we know how to do for fibroids and
Right. Doctor, any other questions at all? Okay, beautiful.
Good afternoon, sir. My name is Dr. Aaron Malcolm. I wanted to ask, are there experiences with repeat myectomies as well? The correct fibroids are HIFU.
majority of our patients have done myectomy. And yeah, so that answers the question. So there are a lot of repeat people who have done myectomy. So we've even seen one for the previous myectomy. So yeah, we see a lot of previous myectomy. No, if you're lucky, one of the things we are afraid of in HIFU is if you have this kind of scar that Dr. Jai showed us, those frightening scars, because the cut might be plastered behind that. But what we try to do is that even if you have that up and down scar, for the transverse scar, oh, we're comfortable. Even if you have had 4 mammectomies with the transverse scar, we're comfortable. But with the up and down, then what we do is we do what we call a simulation to see that the acoustic pathway is safe to get your fibroid. Once that is done, and we're comfortable with that, we have a go. All right? Okay. Well,
We're going online now to take some of the questions. God's power. I want to know more about the very small closure. I don't understand what you said about abdominal pumps. That's Dr. Jumbo.
Okay, thank you, Joshua. The baseball suture, well, sorry, I don't have the YouTube, but you can go through it on YouTube. But it's very simple social techniques, trying to vary most parts of the suture as you are stressing with your continuous closure of the serosa. You take a deep bite, tie, secure it. Lift as you are progressing with your continuous suturing, you leave the first lip from that side, go in and come out on the other side. You rotate it again, leave the side you are coming from, go deep from the second side and come out, such that one side of the suture is what you are seeing, the other side of the suture is buried. So on the line where you do that continuous closure, you will not be able to see the suture you use in the closure, and that will prevent additional formation. Or you can access it on Google. It's a very simple suture techniques. Now, abdominal mop, we said you try as much as possible to minimize injuries to tissues. Now, if you are cleaning blood with mop, you are very, very aggressive. Ideally, when you are using it to clean, just tap. But most cases, you see people dragging, and you even prevent the hemostasis you are trying to secure. So what we advise is use a suction machine and just suck the blood instead of using abdominal mop to clean the blood in the operating field. Thank you.
Thank you very much, Doctor. I'd like to also take another question from Dr. Abodun SOGON. That says, you did not mention lines of management of cervical fibroids. Cervical fibroids. Dr. Victor.
Well, for laparoscopic myomectomy, because of issues of access, you will not want to take cervical fibroids. So if you have cervical fibroids and they're not causing problems, but if you have to operate, you may have to suggest open myomectomy. So for those going for IVF, for instance, once we can, negotiate the canal and we can, get into the uterine cavity for the embryo transfers, we usually don't bother with going for treatment for cervical fibroids because it can do more harm than good. Even the open myomectomy, scarring can occur, cervical stenosis and good.
Dr. Jumbo, this from Olamisi Akintoye says, can you please give some insight into repeat myomectomy, safety and precautions? I know you took it earlier, but this for the benefit of our online.
Okay, thank you, Olamisi. We said one of the major challenge of repeat myomectomy is the intrauterine adhesion, risk of injury to the viscerals. Could involve the bladder, it could involve the intestine. So as such, adequate preparation, counseling is necessary for such a patient. It's not a patient that you live in a rural or peripheral sector. You must have a multidisciplinary team involving the gynecologist, the general surgeon, and the urologist. Should there be any of these complication coming up, they will be able to arrest it properly. And then adequate access is very important. Most times, patients will have had a financial or transverse scar. Ideally, you should go for the midline so that you'll be able to have adequate exposure. Get a free, what we say, virgin area. Once you have done the financial, the pelvis is where your challenge is. When you are coming above or periumbilical area, you're able to see a clear area that you can now guide yourself down to the pelvis and see those viscera you'll be able to do a visualization and remove them. These are a few of the safety concerns. With this skill and experience, team in your have an experienced team, I think you should be able to go and help the patient with repeat myomectomy. Thank you.
Thank you. Another question says, how readily available and accessible are laparoscopy, hysteroscopic, myomectomy, and type? So let me give you
I'll take the first part and then Dr. Derek talk about hypo. One of the issues with laparoscopic myomectomy is availability in this part of the world, but it's available. For instance, I mentioned that at Nordica we've done over 4,000 hysteroscopies, done over 100 laparoscopic myomectomies. So it's available. Yes, not everywhere, but it's available in Nigeria and it's accessible, and the cost is affordable because you look at with benefits and the risks of other options, it's something to pursue. For hypo, I would pass out to Dr.
Well, I remember about 10 years, 12 years ago that we started talking about endoscopic surgery. And people said, oh, it's expensive. Where can we do it? Have you seen the change now in Nigeria? I'm sure in Asaba, we are doing hysteroscopic, some form of hysteroscopic surgery now. So this is the way to make things popular. Continue to talk about them. Let them know that it's possible in your country. It's not Oyibo people don't have 10 heads. We need to bring ourselves up to scratch. So each time I hear cost is an issue, I think it's the height of myopia. Because I remember the same thing was said about, oh, how much is a staff? I remember that conversation with one person. Said, staff for endoscopy? How many people can afford that? And I see now that almost everywhere, well, it's still limited, but at least every town, even in Nnewi, there is a teaching, there is an academy now. So that is the way to start things in a country. So when we talk about those not accessible, is not available for now, but it's going to, that's not the way it's going to stay, especially when some people continue to show you the usefulness of the technology. So I think that's where we are now. It's not, yes, we have the only one in Nigeria, but I'm sure in about 2 years or so, it's not going to be only one anymore. And that's the way things start.
Also, by that token, access God's power. So it's a question also, which is right now in Nigeria, hypo is available only in one place, in Lagos, and we hope that in the coming years, you will have more centers and more machines everywhere. There's a question: why is prior pelvic radiotherapy a contraindication to hypo, since it's not an ionizing radiation?
Yeah, nice question. Yeah, but we don't, just like we said with liposuction, anything that distorts the anatomy, we just, and pelvic radiotherapy shows that there is cancer somewhere. Cancer is what we fear most when we're doing hypo, because we don't have the advantage of taking samples. So anything that is suggestive of cancer, we don't really copy from it.
Right. So thank you very much for our audience online. I think we are coming closer to the end of the session, but before we say we are taking a wrap, I'm going to take the indulgence of everyone in this hall that we will need to step outside for like 5 minutes to take a group photograph to show that we are all here. Some of us, we need to show that picture at home to tell them where we actually are. Saturday, and I'll be in front because I'm saying that you know that I'm actually at the conference, you know. So we're going to have to take that picture outside, then we'll come in. Dr. Mukaja, I'll create a doctor. When we come back, we will take a photo of that for us. Then oh, we have more questions online. Oh, fantastic. Let's take it because I thought the questions have stopped coming. So let's go on. We'll have some more questions. The idea is for the learning experience. I saw something. Oh, sorry. Okay, there's one. Is there any other matter available for protection of patients at risk with recurrent myoma after myomectomy? Dr. Juko, you help us with that.
Proceed, that's Dr. Tosin Yetunde. Okay. Now, the matter of risk of recurrence is multiple uterine fibroids. If they are multiple, and depending on their location and the sizes, most you will see during the open myomectomy, you can enucleate. But there are still some small ones, which in most cases might not be able to, or is not worrisome to that patient at that time. But what you are just trying to do is to remove the bulk of that myoma and leaving a functional uterus. Like some cases, if it's a cervical fibroid, like the person was asking, it can be very challenging. Though it's rare because the cervix is filled with fibrous tissue. But when you enucleate such fibroid, closure is very difficult. And securing in most cases also might be difficult. In most cases, you might do the other myomectomy and leave that cervical fibroid. Now, what I would say, risk of recurrence is precisely on the size and the location of those fibroids. For open myomectomy, the recurrence is far less. You might see in my laparoscopy, just remove the bulk, you can see most of the small ones up front. But studies have shown that it's comparable in most studies, risk of recurrence. But what is important is these small ones that were left behind, they will start growing. And so we encourage as much as possible, once a patient has a myomectomy, we should plan pregnancy. That's the only thing we see that suppresses what? Recurrence. If the patient is able to achieve pregnancy after 3 months, you should be able to think of planning a pregnancy. If you're able to achieve pregnancy, it suppresses that recurrence as much as possible. Otherwise, after myomectomy is done early and patient is still struggling trying to conceive, the risk of recurrence still do what? Become higher. Thank you.
Just to add that the school of thought does not really believe that fibroids will grow, so to speak, to take them out. So it's like new growth. Okay, you generally say current fibroids, but once you take them out, all the ones you left behind, like Dr. Jumbo just said, tiny ones you did not see, they now become obvious as they grow. Yeah, but I still want to add, I think, it will be interesting for us to look at this recurrent fibroid. Because I'm sure a good number of them are adenomyosis. And if we can see that the evidence that we have in our environment is showing us that at least 30% of what we call fibroids are adenomyosis. So definitely from the time you're starting, this patient is going to have a recurrence when you're doing malfunctioning for adenomyosis. So if there is going to be any matter, I think CA125 might help you to see if there are adenomyosis. So even if you are not doing MRI, okay, for example, you cannot afford MRI, and you can afford to do it, CA125, because that will show you that there is a placenta tissue somewhere, or there is a endometrial tissue somewhere. Okay, and if it is elevated, that might just be a suspicion that you are already dealing with adenomyosis, and that kind of counseling might be different. So I think that's what I will look at. Just to add another soft marker, which might not even be imaging, is we see patients who say the last time I had a myomectomy, they didn't break out anything. The doctor kept cutting and histology, medical reports. One thing in this environment sometimes is when you ask for medical report of your previous procedure, sometimes the patient cannot get it. Sometimes the previous hospital that they do not even have records, or they are refusing or being difficult getting this report because it can help future management. Because just like you said, adenomas is a consideration. And if you're not sure, MRI is available to also help differentiate.
Now, there's another question from Dr. Victor. Says, what is the treatment for 1 year amenorrhea following intrauterine admission post myomectomy? That's another Dr. Victor will have to answer that one.
I hope I wasn't the one who posted the question.
One Victor to another Victor.
Yeah, so it depends. If you made a diagnosis of intrauterine additions, done your hysteroscopy. What one will advise is hysteroscopy, and that does two things. What is the extent of these additions we're talking about? And then to also treat the additions. So treatments will include isolysis, and then we usually take steps to prevent recurrence of future additions, also further additions. Sometimes we put a coil, IUCD in the cavity, and place on hormonal medications, estrogen and progesterone. Sometimes for a month or two, and then we do some cases we need what we call a second look hysteroscopy to check and see what we have. Have we cleared our additions? Do we need to do more? So sometimes you have multiple hysteroscopies. So sometimes you are lucky, things are fine, she's now okay to go on. But when you have difficult cases, sometimes continuous analysis and other options. It also depends on what she is trying to achieve. Okay, if she has completed her family and the amenorrhea is just a problem, then just let her be. But if you have to go for assisted conception, again, if the cavity has been assessed and okay to carry a pregnancy, you can always induce menses. Okay, we have methods of inducing menses to start the treatment of this patient. So the treatment depends on whether she's in her own eggs or donor eggs, and all, but we know how to manage that when it comes to the fertility part. But if the additions are so bad and that cavity that judged to not be able to carry a pregnancy successfully, because not just to carry a pregnancy, but complications in pregnancy and bleeding issues, placenta, and all that, we may be advising surrogacy if we think that that's the line of treatment. So it actually depends. You have to individualize this patient and see what the ultimate end game is.
Doctor, there's a question from Elon, and it says, the para-2 woman was had open myomectomy twice at 39 years, now having recurrence. The third time, what will be the line of management? I think it was mentioned for the benefit of Elon. Let's just go through it.
It's still a recurrent fibroid. You evaluate this patient. What does she want? Does she still want further pregnancy? Or is she symptomatic? If it's symptomatic and is still considering further pregnancy, the option is for myomectomy. But those safety nets has to be there. However, this one, if she has completed her family para-2 and the two are alive, it might be better for her to have what do you call it now? Hysterectomy. But this hysterectomy is still going to be what? Assisted with increased mobility and mortality because of the additions that she would have gotten from the first and second repeated myomectomy. So it's quite challenging, but she has to be fully evaluated depending on the size of that fibroid. That's what will dictate the next line of management.
All right, thank you very much. One more. Before we do
myomectomy for this patient, I will recommend that she has an MRI. If you have had a patient who has had 2 repeats myomectomy, before you take her to the theater, do an MRI. It's cheaper than taking the patient to the theater and coming back to come and say, I could not remove anything. Because it might be adenomyosis. What I want to leave doctors with today is probably not even high, is adenomyosis.
Right. There's a question on, can any of the presenters elaborate on the management of calcified fibroids? Calcified fibroids.
Okay, for laparoscopic surgery, myectomy, we have dealt with that calcified fibroids, but yes, that can be more difficult to do. And I mentioned the issue of conversion. Sometimes you have difficulty removing these fibroids. You may have to do what we call laparoscopically assisted abdominal myectomy. So the difference will be that incision, you have to expand the incision, make a larger incision than your laparoscopic incisions, but not as large as it's like a mini lab essentially. So sometimes you have challenges like that with taking out calcified fibroids, but we've had cases where we've taken care of this, so it's possible to do. Okay, I'm sure for whom I mentioned it's not a big deal.
The calcified fibroids are not good for eyes, so we don't want to take them.
Another question from Jay. He says, what are the best or effective ways to manage the menorrhagia medically if the patient doesn't want surgery?
Okay. Thank you. You just have to individualize the patient. He has choose the options of medical management. So you look at her symptomatology. Is the menorrhagia so much? Is she desirous of pregnancy? If she's not desirous of pregnancy, there are options for her. Now, evidence has favored the uterine system. You might think it's not available. It's readily available in Nigeria. So it's progesterone impregnated IUCD, and it's highly effective. You can put it and have a dual function for her to protect her from unwanted pregnancy, and also the menorrhagia is corrected until she make up her mind for what she wants.
Thank you very much.
Sorry, there's one surgery also. I don't know why it is not common in Nigeria. Yeah. Uterine ablation, endometrial ablation. Why are we not doing endometrial ablation? It's so simple, 15 minutes procedure, if you know how to do it. And the patient is good for it. So I think that's one other thing that we probably also need to put into our armamentarium. But don't forget where it started from. It's not for everybody. You select the patient, but it should just be one of the things. For example, you have a 40-something-year-old, and all our problem is menorrhagia. But of course, you must discuss with that, and also that's one of the things. Managing patient expectation, explaining to the patient what you want to do, give the patient all the options that are available, and let her make the choice.
My question is on I'd like to know the specific age of women who undergo this procedure, especially women who are eager to have babies with huge fibers. When do you advise them to get pregnant, taking into consideration the huge necrotic cavity from where destruction of the fibroid was done?
Okay, so no hiding place. Yeah, the age. Actually, let's differentiate. I think it's for people who want to have children and people who don't want to have children. So age is really not a consideration. Once we are not, there's nothing suggesting cancer. Age is not an issue. For women who want, that's why we say after HIFU, we do hysteroscopy. We want to assess the uterus itself. There are some women, you see, they come with the uterus is already 32 weeks big. You want to come and do HIFU before you do IVF, or you want to get pregnant naturally. Okay. In 1 year, HIFU can reduce that by 75%. Where are we? Do you understand? So it's still like that you still have a pregnancy in situ. So such a patient will probably, we tell them that, look, these are the possibilities. If you want to do open mammectomy, go ahead and do it. If you qualify for laparoscopic mammectomy, go ahead and do it. But with HIFU, this is the best we can do for you. We're not sure with this mass whether you'll still be able to get pregnant after. If the problem is not in getting pregnant, Dr. Agai told us, is that you can carry the baby even to term. If from the get-go, your uterus is already 26 weeks, where is the baby going to stay now? Do you understand? So those are the things we need to look at when we're addressing this kind of patient. So it depends on what we're starting with, how big the uterus is. And that will, sometimes some of these answers are not one size fits all. You have to look at the patient and be able to advise the patient properly. Right?
Okay, there's a question on preventive medicine is the way forward currently. Are there research as to things one can do to prevent fibroids, seeing a high rise in number of cases, more so inseminations for infertility? Dr. Jumbo, help us.
Okay, thank you. Okay, thank you. So, fine, we said the cause is not known. There are so many things that have been suggested. But by and large, what research has shown is that there are two things that can help prevent it. One is smoking, and two is pregnancy. But you look at the benefit of smoking. Sorry, when you compare the risk and the benefit of smoking, can you advocate for it? So that is why it's still very, 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 very limited. So for what we advocate as much as possible is pregnancy. We understand we are career prospects, but let us not forget that we still have a role to do what? To raise our what? Children. So someone is 45 years or is 30 years of age, and then he's not getting pregnant, he's not planning for marriage, he's not getting pregnant. Except it's infertility, we know we need to evaluate and treat. But if there is no, that's the ideal time to get pregnant and plan what? Your family. That goes a long way to do what? To prevent it. But we said it's hereditary. You can see it. If somebody has had it in your family, the tendency for a lady to have it is still there. So I saw a patient, she was 22. The elder sibling is 26 with huge fibroid, 34 weeks. And hers is already 12 weeks size. Now, the first one has not gotten married. The one in 22 is already pregnant. Are you getting it? So it's quite difficult. He was saying he wants to terminate the pregnancy. I say, with what you are seeing, you go ahead. Say over his head, everybody won't terminate it. And it's carrying the pregnancy. That will go a long way to do what? To suppress the growth of that fibroid for her. And the other one, 26, we will be going for that myoventure. So what we see is pregnancy that we can say in our environment. Plan. Once you are ready, 26 graduates, think about it. Don't wait till you have PhD and you are 45 with 36 week size fibroid. Don't know what else we can do. Thank you so much.
Yes, I agree that pregnancy can reduce the risk of fibroids. But sometimes I think we are oversimplistic about this. And this is what I mean. Some of these patients is not that they don't want to get pregnant. They can't get pregnant. Some of them, you know, and that's why I'm talking about adenomyosis. Because sometimes some of those who have adenomyosis also have endometriosis. Okay. And it's affecting, is not, and I think we need to look at, when we look at the relationship between infertility and fibroids, that might be the missing link. I'm not saying it's the missing link, That might be the missing link, because I remember there was a study that was done in UCH in the 90s that somebody showed the relationship between fibroids and peritoneal adhesions. And said patients who have fibroids tend to have more peritoneal adhesions in fertile patients. And so, for me, I've been asking myself that question, why? So sometimes we ask patients to go and get pregnant, and they are ignoring it. I will not, there's a professor, very senior person, one of these endometriosis programs. So he was sitting down on the high table with one of the sufferers. And the professor mentioned that pregnancy prevents endometriosis. She just came down, she said, look, Dr. Guy, I'm just respecting you. I will have abused that old man today. Now, what does he think? That I don't want to get pregnant? You know, so sometimes it's you talk the runners of some of these patients because you don't know what they're actually facing. Yes, we can recommend that they get pregnant. Yes, it is true, but we need to be careful how we say it because some of them are even trying their level best and it's just not happening. So it's a bigger problem than we see, than we imagine.
Just to also add to that apart from social issues, no right partner, education, and all that, some actually want to get pregnant, but they cannot. And we have delayed referring them to where they can get pregnant. Sometimes they need assisted reproduction. We've delayed that. So it's two problems in one now. They've not achieved pregnancy, which in code would have reduced the risk of fibroids. Now they have fibroids already. And recall the study I mentioned that we did, where we found that fibroids were more in size and number in women with primary infertility versus those with secondary infertility. So, and the mean age of presentation to us for infertility was about 38 years. So it's a combination of factors. They presented late, sometimes because we have not recognized that they are struggling to get pregnant. Like example, Dr. Ajayi gave now, the endometriosis will not even allow 50% or so women with endometriosis will not be able to get pregnant. So you tell her to go and get pregnant to prevent, go and get pregnant to prevent, to take care of her endometriosis. Meanwhile, the endometriosis is not allowing her to get pregnant. So I think we should also note this point.
Thank you very much, Dr. Ajayi. At this juncture, I would like us to go outside for our photo session. For our online participants, keep the questions coming. We will send responses to you after this event. So just keep dropping the questions on the Q&A button and you'll find your answers after the program. We're trying to cook up for time here physically in Asaba. So I'd like us to go table by table, so it's easy. So we'll start from this table. We'll start from this table. After the photo session, we'll be going for lunch at the restaurant, and we'll then do a follow-up at somewhere. I think that's going to work that. So we'll start from this table. So it's easier. We don't crowd the aisle.
Somebody is asking for Dr. Kumbo.
Don't worry, nothing will happen to your class. Okay. For you. No, I haven't.